Hello, and welcome to Chagpar MD. I'm Dr. Anise Chagpar, and this week I have a very special guest. Dr. Sarah Goldberg is an associate professor of medicine and medical oncology here at Yale Cancer Center, and she studies particularly lung cancer. And so I thought, who better than Sarah to talk to us about some of the novel treatments that are going on in lung cancer in terms of targeted therapy and immunotherapy, because lung cancer truly is one of the most common cancers that are out there. So what do you say? Let's get started. Hi, Sarah. Thank you so much for joining me today.
Thank you so much for having me.
So, Sarah, let's level set first. Tell us a little bit about lung cancer, how common it is the incidence going up or down? Is it as lethal as it used to be? And who gets it anyways?
Okay, well, lots of questions. Lung cancer is a very common cancer. It's not the most common cancer. Breast cancer in women and prostate cancer in men are more common than lung cancer, but unfortunately, lung cancer is still a lethal disease. We often will see patients who are diagnosed with more advanced disease, stage 4 lung cancer. But even in the early stages, it can be a lethal disease for some. And so because of that, it's the most common cause of cancer deaths in the United States. And so it's not the most common cancer, but it is the most common cause of cancer death. The treatments have absolutely gotten better. We've improved how patients are doing, how they're living, and how long they're living. And so the mortality has gone down for lung cancer, which is really great news. The incidence has also decreased. I think most of that is due to smoking cessation. So patients who, or people who quit smoking, years or decades ago, we're starting to see the really good effects from that now.
And so one of the common misperceptions, I think, that is out there is that if you have never smoked, you cannot get lung cancer. Is that true? Or what are the other risk factors of lung cancer?
So anyone can get lung cancer. I guess anyone who has lungs, which is, most of us. So lung cancer, smoking is the biggest risk factor for lung cancer. But as I often will tell my patients, just because someone smokes does not mean they get lung cancer. And someone who's never smoked a day in their life still can get it. So although it's a risk factor, it's not the only one, because you can get lung cancer without ever having smoked. The other risk factors are harder to really describe or explain. There's some research and work that shows that radon might be a risk for lung cancer, although it's not nearly the same as smoking. And many of us live in areas where there is radon in the environment, and it's really unclear how much radon is a risk, and so there's still a lot of questions about that. Beyond that, we really know very little about what causes lung cancer in people who've never smoked. There's some association with asbestos, but even that is difficult to really pinpoint. So it really is smoking that remains the biggest risk factor, but still, even without smoking, it's still possible to get lung cancer.
And is it the smoke or is it the tobacco? So, for example, a lot of people who watch this YouTube channel are from other parts of the world where chewing tobacco or betel nut is very common as a social habit. And we know that increases the risk of oropharyngeal cancers, but does it increase the risk of lung cancer, or is it really the smoke in smoking that causes lung cancer?
Yeah, it's really the smoking that causes lung cancer. As you're saying, other forms of tobacco cause oral cancers and other cancers, but not typically lung cancer. So it's really smoking that causes lung cancer.
And is there an association between the amount and duration of smoking? So, for example, if people have tried smoking in college, but it was one cigarette and they kind of hated it, and then they never smoked after that, are they still at increased risk? And what about the people who have smoked all their lives and say, listen, I'm 72 years old, I've been smoking since I was 14, I haven't gotten lung cancer yet, I just, there's something about my genetic makeup that means that I will never get lung cancer?
Yeah, those are all great questions. There there is absolutely an association with how much someone has smoked and their risk. So I see, people who smoked, a couple of cigarettes a day during college. That's a common one that people tell me. And, someone who smoked in the past and then quit 50 years ago, some people who quit decades ago. There is an increased risk with the more someone has smoked. People who smoke just a few cigarettes in their life or, just for a couple of years have a much lower risk than people who have smoked for decades. And the other thing that comes up a lot, similar to what you're asking about as well, when I quit, does my risk go down and does it ever go back to zero? So the risk does go down when you quit. So I tell people, even when they already are diagnosed with lung cancer, that it's still important to quit. First of all, just your lung health overall and your overall health improves when you quit. But your risk of getting another lung cancer will go down if you quit. So quitting any time is still a good thing and decreases your risk of lung cancer and other illnesses that come with smoking. So there is an association with how much someone smokes and when they quit and all of that. There may be something about someone's genetics that puts them at risk of lung cancer and smoking, and the risk of lung cancer in smoking, with smoking. But the idea that you were asking, in someone who hasn't gotten it yet, should they just not even bother quitting? I still think it's important to try to quit if someone's motivated to do so. Again, the other illnesses that come along with smoking, heart disease and lung issues, those are still something that can get better with time in someone who quits. So still important, even in someone who hasn't gotten lung cancer yet.
Yeah, and there are, the one thing is that it's really difficult to quit, right? And we all know
Absolutely.
that. We can
oh
all
my goodness, it is hard.
empathize with that. But there are resources for people to help them to quit. So can you talk a little bit about that? And don't worry, folks, I will leave you links to some great resources in the description box below as well. But Sarah, what do you have?
Yeah, so you're right. Of course, smoking it's addictive and it's extremely hard to quit for many people. People always tell me, "Oh, I've been trying to quit for years," or "I quit and then I went back." So there are a lot of things that can help. There are several different types of medicines that can help people quit. People often know about nicotine replacement. There's patches and gum and all these different things, but even beyond that, there's other medicines that can help. And then it's been shown that going to smoking cessation counseling or groups can also aid in quitting. We have actually a great program at Yale, some really amazing people who run our smoking cessation program, and they can be a huge help to people who are interested in quitting. So yes, there's absolute resources. It's great to put those out there for people if they're interested.
Yeah, so for those of you who are watching, if you're around any kind of major academic center or cancer center, they invariably have a smoking cessation program. For those of you in the United States, there are quit hotlines. I will leave you the links for those. The CDC has a great program with web-based apps and all kinds of things for you to check out. So then the next question is, Sarah, with regards to screening. Let's suppose you are a heavy smoker. Should you get screened? And if so, with what and how often?
Yeah, so great question. So yes, you should, at the very least, talk to your doctor about getting screened. So for a lot of years, there wasn't lung cancer screening. So, we've had mammography for breast cancer and colonoscopy for colon cancer. There wasn't really the equivalent for lung cancer. But then in the last couple of years, there's been results of studies that have come out that show that lung cancer screening does save lives. So now it's become part of our standard, a standard part of of primary care. A primary care doctor should talk to people about lung cancer screening. It's only been so far shown to be effective in people who are at higher risk of getting lung cancer. And that definition changes over time, but it's basically people who have a smoking history and are within a certain age and have quit within a certain, or still smoke or quit within a certain amount of time. That basically tells someone's doctor if they're eligible for screening because their risk is high enough to make it worthwhile. And screening is done with a CAT scan. It's a pretty quick test. It's more than just an X-ray, but it's a pretty straightforward test that can be done quickly, and it's become part of our standard. So it's something that should be discussed with primary care doctors or lung pulmonologists if someone has a lung doctor. And we can find a lot of times early lung cancers that could be cured. So it's important to see if someone is eligible for lung cancer screening, and then ideally to go through with it if they are.
Yeah, and that goes back to what you said at the beginning, which is, lung cancer being such a lethal disease, if we can catch it earlier, you potentially can get a jump start and find these things when they're curable, which leads me to this question. For our viewers who are in the United States, is lung cancer screening covered by insurance?
I think it typically is. It's a guideline. It's part of the guidelines now for how we should be screening. I think as long as someone is within those guidelines as set by, I think it's typically Medicare, and then other insurances follow suit, I think that it should be covered. Don't hold me to it. I don't make the rules about those sorts of things, but my understanding is that it typically is covered, and that could at least be discussed with someone's doctor and insurance companies and all of that to see if it's allowed or if it's covered. It's been an evolving story. Even just a couple of years ago, it wasn't standard. The results from that study were not in, and so we didn't know. But now that we know, and it's part of the recommendations, I believe it means it should be covered.
Yeah.
Again, don't hold me to it. For anyone in the insurance company, you don't always know, but I think that it should be. I mean, it's now standard, so it should be, as long as someone has the risk there.
Yep.
And I agree with what you said before. Just to go back to something you said. If we can find lung cancers earlier, that is always better. That gives us a much better chance of curing it. One of the biggest problems with lung cancer, I mentioned this at the beginning, is that we often don't find it until it's advanced. And that's a lot of times it's because people don't have symptoms of lung cancer until it's more advanced. Just a small spot in someone's lung, they may not even know it's there. They may not have the typical symptoms we think about. And so if we can find it early before it spread and cause someone symptoms, at that point, it's much better.
Yep. So for those of you who have a smoking history, talk to your doctor about screening. And if it's not covered, advocate for yourself and make sure that you talk to the politicians who make the rules and see if we can't get it covered. But Sarah, I want to get back to that point of, let's suppose that, you haven't had a 50-pack year history of smoking. You don't meet the screening guidelines, but you know that you've been smoking for a while and you know that you're at increased risk. What are the signs and symptoms that you should be looking for, given that, this, like so many of the other cancers that we've talked about on this show, can be a little bit silent. I mean, we did a show with Elena Ratner on ovarian cancer, which, they talk about ovarian cancer being the cancer that whispers. We did a show with Jill Lacey on pancreatic cancer, again, one of these silent killers. What are the things in lung cancer that we should be looking for, given the fact that it's not one of those that comes out and screams, hello, something's wrong?
So sometimes people do have the classic symptoms you would think about that are associated with the lungs, and that can be cough, or if someone already has a cough, let's say that they have a smoker's cough, a change in the cough, increased frequency of cough, bringing stuff up, sometimes shortness of breath. So I sometimes will hear from people and they'll say, oh, I always have a cough, but it changed. Something is different. It's more often. It's more severe. That's something to definitely bring to your doctor's attention and think about if you need a scan for that. Sometimes it's more non-specific symptoms, just feeling more tired or change in, lower appetite, losing weight. Those are sometimes more non-specific symptoms. Those could be symptoms of a lot of different things, but sometimes we see that with lung cancer too. Sometimes pain, if the cancer's in a certain area in the lungs or in some other part of the body, sometimes it can cause pain. So that we sometimes see as well.
Yeah. So again, I find that oftentimes it really is kind of this phenomenon, like if you see something, say something. So if something's out of sorts, you really need to bring it to your doctor's attention. So Sarah, you talked a little bit about finding cancers at a later stage. Can you walk us through kind of the stages of cancer and how you approach the management for each of them?
Sure. So all different cancers have different ways of assessing the stage. The stage, as what I tell my patients, is the stage is it just tells you where in the body the cancer is in a cancer like lung cancer. And so it's a way that we can say, the cancer is in this part of the body, or it's gone to this part, and that's how we figure out the stage. And so in lung cancer, and every cancer is staged differently, but in lung cancer, the way that we generally think about it is stage 1 is an early cancer, and so it tends to be in the lung only. It hasn't gone anywhere else yet. And these are generalizations because there's some nuances involved in the stages. But in a stage 2 cancer, for the most part, it either is a larger tumor or it's one that has gone to the nearby lymph nodes in the chest. A stage 3 cancer is one that typically has gone to other lymph nodes that are further along, so more towards the middle of the chest, something we call the mediastinum, or sometimes the lymph nodes over the collarbone. So that's in the stage 3 category, and each one of these is a bit more advanced. Stage 4 is really anything beyond that. So if a lung cancer spreads beyond the lymph nodes, either to the other lung or sometimes to the lining around the lung or to another part of the body, that's considered a stage 4 cancer. So again, those are some generalizations. There's some more nuances there, but that's the general way that we think about how to assign stages to lung cancer.
And so how does treatment vary with all of those stages?
So that's why staging is so important, because it really helps us figure out the right treatment for someone. So usually for a stage 1 or 2 cancer, so again, that's one where the cancer is in the lung or the nearby lymph nodes, we usually will think about surgery for that situation as the initial management for the most part. And so that's the type of cancer that the patient should definitely see a thoracic surgeon, a surgeon who specializes in lung cancer, and think about whether surgery is possible or the right thing. Sometimes we do think about radiation for those cancers, and some people just say that there's no way I'm getting surgery, or maybe they're not quite healthy enough for surgery. And so sometimes radiation is considered for those people as well. For a stage 3 cancer, where the lymph node spread is a bit further but still within the chest, those patients we typically will think about radiation, not as much surgery, although sometimes we'll consider it, but usually it's radiation, and a lot of times we'll combine the radiation with chemotherapy. So that's a common treatment we'll give to people for stage 3 cancer. And actually a big change in the management of stage 3 lung cancers is that we've now added immune therapy to that treatment strategy. So for many years, we were giving people chemotherapy and radiation, sometimes surgery for stage 3, but now based on the results of a fairly recent study, we found out that adding immune therapy can help people live longer, improve the chance for curing this, improve survival. So that's been a huge advance that we add immune therapy to that management. And then stage 4 is as I said before, it's the most common presentation for lung cancer. We see most people who have stage 4 disease. And so that management has evolved tremendously over the last 2 years. Because stage 4 cancer means that it's spread outside the chest, we rely on what we call systemic therapy, meaning a medicine that gets into the bloodstream, goes throughout the body, treats cancer wherever it is. That could be a variety of things. A few years ago, it was really just chemotherapy for lung cancer. But now we still use chemotherapy sometimes, but now we have many different types of targeted therapies that we use for stage 4 cancer, and also immune therapy. That's become a huge part of the treatment of stage 4 cancer. So lots of different options for use in people who have stage 4 cancer, and a lot of that depends on different features of the cancer and what we think will work best in someone.
So let's dig into that a little bit further. Because stage 4 is the most common, let's kind of start there. So how do you decide who should get chemotherapy alone versus chemotherapy plus a targeted therapy, or a targeted therapy alone, and who should benefit from immunotherapy, and how does all of that work?
Yeah, so as a medical oncologist, that's a lot of what we think about and what we do. And again, that's what's really changed over the last couple of years so much. Thinking about when I started practicing, about a decade ago, it's really even changed in that time frame. So, I think the first step when someone has a stage 4 lung cancer is to look at the features of the cancer that will help us to predict which treatments are most likely to work. And so what does that mean? Well, basically it means two main things. One is to look at the mutations in the cancer, and 2 is to look at what we call the PD-L1 expression. So PD-L1 is a marker on the cancer that helps us to figure out if immune therapy is more or less likely to work. And so by having that information, and then also having the mutation information, we can figure out the best treatment. So for certain mutations that we can find in the cancer, we have targeted therapies that will kind of match up with the mutation. So you know that there's a mutation that is an abnormality in the genes of the cancer, and then we have several different targeted therapies that we can use based on which mutation we find. And so if we find a mutation and we have a targeted therapy, that's the treatment of choice. That is typically what works incredibly well for people, and can really shrink the cancer, make people feel so much better, help them live for a long time with this. And so if we find a mutation that we have a targeted therapy for, that's our treatment of choice. Typically without chemotherapy, without immune therapy, the targeted therapy alone is enough. And that's usually a pill too, which is really nice for people, so they don't have to come in to get an IV infusion. So that's how we decide that part. Now there's many different targeted therapies based on which mutation, and even within the mutation category, there's lots of different treatments. So there's some more details there, but that's the general idea with targeted therapy. And then how do we decide between chemo or immuno, or really both we sometimes use? Well, that a lot depends on that PD-L1 expression. So if we have a high level of that, sometimes we'll actually use immune therapy on its own. So we often, or sometimes I'll say, don't even use chemotherapy in people who have lung cancer, at least not initially. And we can use an immune therapy, and it can work really well for people for quite a long time. In people who have lower expression of PD-L1, that's when we start to try to think about combining things to help them work better. So adding the immune therapy to the chemotherapy. It's actually pretty rare these days that we use chemo on its own. When we combine it with immune therapy, it seems to work better. And so the only time we're really using chemo on its own anymore in stage 4 lung cancer is really if someone has some sort of reason to not be able to get an immune therapy. And so there's a couple of reasons why you might not be able to get it, but otherwise we try to give them both together, or even immune therapy on its own.
So when you talk about these mutations, you're really talking about the mutations that are found in the cancer based on a biopsy, right? So this isn't like the blood test.
Well, so it could be either, actually. So for a long time, we were just doing mutation testing based on a biopsy and getting a piece of the tumor tissue and then doing the mutation testing on that. And that's a lot of times what we still do. But in the last couple of years now, there's a blood test. Well, there's lots of different types of this test, but there can be a blood test where you can look at the mutations in the blood. And so that really has changed our management for people. You know, a lot of times we would get a biopsy, we'd make a diagnosis of lung cancer, but sometimes you don't have enough tissue to do the mutation testing you want to do, or you know, it's in a different hospital and we can't get it here quickly. And so it sometimes creates challenges there. We used to have to biopsy people again, which isn't ideal. We still sometimes do, but what we now try to do is to get a blood test, and we can get something called circulating tumor DNA. So it's actually the cancer sometimes will shed its DNA into the bloodstream, and we can get a blood sample, and there's these really strong assays that can pick up these small amounts of cancer DNA in the blood and can give you the information you need. So that's something that we will use in clinic sometimes when we don't have the information from tissue, or if we want to supplement it for whatever reason, we'll get a blood test. That could be, it's a really amazing technology that now we're able to do that.
Yeah, but that is different than genetic testing or germline testing, right? Do you want to kind of differentiate that? Because a lot of people, when they think about mutations and they think about genetics, they're thinking about, you know, getting a blood test that'll tell you about your risk of developing cancer. For example, a BRCA mutation will increase your risk of developing breast cancer. What you're talking about in terms of liquid biopsies or circulating tumor DNA or circulating tumor cells is a little bit different. Do you want to clarify that?
Mm-hmm. Of course, yes, this is so important. So when I'm talking about getting the biopsy or the mutation testing from the tumor tissue or from the blood, I'm talking about looking just at the cancer DNA or the cancer mutations, which, you know, if someone has just a mutation in their cancer, that does not mean they have it in any of their normal cells, or what you are referring to as germline, meaning it's part of every cell in their body. So that's not the type of mutation I'm talking about. In some other cancers, such as breast cancer, we sometimes do find these germline mutations that someone has, like BRCA. But in lung cancer, those are very, very, very rare. And so the mutations I'm talking about, whether it's blood or tumor testing, are all cancer mutations. And so people, because it's not in the DNA, in the normal DNA, in the normal cell DNA, you can't, it's not something you inherit. It's not something you can pass along to your kids. So in lung cancer, we're talking about the cancer DNA, not the person's DNA that has the mutation. So yes, even though it's a blood test, it's totally different than getting genetic testing of your own normal DNA or own normal cells.
But the cool thing about that is that when you have a targeted therapy to that particular mutation, it's kind of like you said, it's very targeted in the sense that you reduce the side effects because you're really only going after those tumor cells. So if you have a mutation that you have a drug for, they get targeted therapy. If they have high PD-L1 expression, they get immunotherapy. If they have neither, do they get chemotherapy alone, or do they still get the immunotherapy? Because I find that in talking to some oncologists, for some particular cancers, they find that treating people with immunotherapy, even if they have lower or even no PD-1 expression, they still kind of benefit with immunotherapy. How does it work in lung cancer?
Yeah, so that's the case in lung cancer. So, so even with low or no PD-L1 expression, we will use immune therapy, again, unless someone can't receive it for another medical reason. Because you're right, and I don't know that anyone could quite explain it, but even without that expression of that marker PD-L1, people can really benefit from immune therapy. But in those cases, we typically will combine it with chemo. And actually, one thing I'd like to clarify, because I haven't really said this yet, but I think it's important. So far, what we've talked about really is non-small cell lung cancer. So there's really two main types of lung cancer. So we really are focusing on non-small cell lung cancer, which is by far more common than small cell lung cancer these days. And so with small cell lung cancer, we're actually typically always using a combination of chemotherapy and immune therapy. PD-L1 testing doesn't really tend to help us all that much with small cell lung cancer, and using immune therapy on its own, at least as initial treatment, it's not really thought to be useful. So we usually do combine it for the small cell lung cancer, regardless of what the markers show us.
And do those cancers also benefit from targeted therapy, or is that really for non-small cell only?
Yeah, so it turns out that in small cell lung cancer, it's very rare to find a mutation that we know how to effectively target. So sometimes I'll still do the testing and see what we're able to find, but for the most part, and we're just not as fortunate with the small cell lung cancers that we can find something that is targetable. It's a huge area of research trying to find good treatments and targeted therapies and other ways to effectively treat small cell lung cancer, but so far we haven't made as much progress with the targeted therapies for small cell.
And so when we think about, when we started this show, we talked about lung cancer being, a pretty lethal cancer. How much have we really moved the needle in terms of targeted therapy and immunotherapy in terms of extending survival? Like, does it really make a difference?
Oh my goodness, absolutely. So we have, and this has been proven in study after study, we are improving survival in people with advanced or stage 4, either, whichever one you want to call it, lung cancer. We absolutely are. When we can find a mutation and target it, people live longer. When we treat with immune therapy, unfortunately not everyone benefits from it, but when someone does, people are living longer. And so these treatments have improved survival, and they're mostly now used in stage 4 cancer. We're starting to figure out how to use them in earlier stage cancers. And so I don't know as much in that realm yet in the earlier stage cancers, but we're starting to figure it out. But in stage 4 specifically, where they've really been studied for the most part as of now, we are helping people live longer. And I would say better, when you use chemotherapy, when you use some of the older drugs, there can be a lot of side effects. Some people do just fine, but there can be side effects that can affect people's quality of life. And the targeted therapies and the immune therapies, it's like a win-win. They work better, and they help, they're better with side effects as well. And so these are really making a big difference in people's lives because of that.
So Sarah, some patients, they've heard about chemotherapy and they really are kind of hesitant to pursue it. And the idea of targeted therapy and immunotherapies being a little bit more specific, a little bit newer, having a better outcome seems a little bit more palatable, especially the targeted agents, which are now oral.
Yeah.
But they may still wonder, like, how much bang am I getting for my buck? When you say extend survival, do you mean by like a couple of weeks, a couple of months, a couple of years, a couple of decades?
Yeah. Yeah. So it's impossible to know for any one person, right? So you know, when I'm talking to one person in front of me in the office, it's impossible to know. I wish I could. I know that's what everybody wants to know, but you don't know. What we know is what we've learned from clinical trials, where, you know, groups of people have tried one treatment versus another treatment, or maybe one treatment versus that same treatment plus another drug. And so what we see is that these, you know, we're talking about two different things, targeted therapy and immune therapy. In the right populations, in the right patients, where we've picked people based on the features of the cancer, and we've been smart about selecting patients based on the features, the mutations or the PD-L1, those trials have shown us that people can live for years longer because of it. I mean, I wish I could say decades. Maybe one day I can, but we really have improved survival by a long time. Now, again, it's not everyone. The treatments are still not effective enough, right? I wish I could say everyone benefited for years, but there are people with stage 4 lung cancer who can live for many years because of these treatments. And so it's really been a huge impact.
Yeah, I think putting it into that context really makes it sound like, you know, this is worth a shot. It's worth a conversation with your oncologist. If you have trepidation about this, I mean, the studies really have shown a tangible, durable benefit.
Yeah.
Especially in stage 4 disease, which I think gives the heebie-jeebies to just about anybody in any cancer. When we talk about the earlier stage cancer, so when we were talking about stage 1 and 2, and you said, you know, really that's in the realm of surgery and radiation, do systemic therapies have any role to play in that setting in terms of preventing recurrence, or do you kind of keep that in your back pocket if and when the need should occur?
Yeah, thank you for asking. I had forgotten to mention that. So for stage 1 cancers, the smaller cancers that haven't gone to lymph nodes, those typically are treated with either surgery or radiation, and that really is it. And we keep an eye on things afterwards, but we don't usually treat with additional therapies. The stage 2 cancers, though, the ones that, especially the ones that have spread to the nearby lymph nodes, we will at least consider chemotherapy after surgery, what we call adjuvant chemotherapy, that has been shown to decrease the risk of recurrence and improve survival. So we will at least discuss that with our patients, and, you know, if they've had a successful surgery where it seems like it's all gone and everything is out, we still will even then consider whether chemotherapy can help to reduce the risk of it coming back.
And when you say chemotherapy, do you also include in that bucket targeted therapies?
Yeah, you're getting into more of a gray zone here where we're still trying to figure that out. Until very recently, no, it really was just chemotherapy. We're just starting to see some data on maybe for people with EGFR mutations. That's one specific mutation that's maybe in about 10 or 15% of lung cancers, that maybe we can use a targeted therapy after surgery as well. And that also does seem to improve outcomes. It's still early days for that. We don't have, you know, final results from that trial. It's not yet FDA approved, although at some point it might be. But it's something that might be coming soon, where we're going to start to use more than just chemotherapy after surgery to improve survival.
Yeah, I mean, it just kind of makes intuitive sense, though, right? Like if a cancer has, for example, an EGFR mutation, and you have a drug against EGFR, and you know that that's effective in the metastatic setting, why would you think that it wouldn't make sense in the earlier setting?
Yeah.
But I guess we always need to do the trials to see.
That's right. And so we've been waiting for a long time to see the results of that trial, and we just heard it a few months ago. It actually was the one, I think the senior author on that paper was Roy Herbst, our chief of oncology here. So I think that's something that may be coming soon, and is something that we're already starting to think about in the clinic, whether we should be using an EGFR therapy in people with earlier stage lung cancer. Because, in stage 4 cancer, we're very effective in a lot of ways at treating it, but we're not able to cure it. We can't take it away. We can't make it go away permanently. But in earlier stage cancers, we can. And so really the question there is, will these drugs improve our chance of curing it? And that's really what we're still trying to figure out.
Yeah, well, so many exciting advances in lung cancer, not only from the therapeutics, but also in terms of screening and risk reduction. It was great having Sarah as my guest here today on CHAGPAR MD. I hope all of you enjoyed this video. I hope that you'll like, share, and subscribe. Do let us know what other topics we can bring you that could be helpful. Until next week, this is Dr. Anise CHAGPAR wishing you all a safe and healthy week.